Everybody. Yes, nice to see a lot of familiar names here. Welcome. I think those of you who were at the recent aortic meeting in Dhaka will be familiar with the talks we're going to give, but I can see there's some people who have not. So this morning the talk is introducing the work that's being done on cancer surveillance in Africa, how the material is connected and some of the results. So the first talk is going to be given by Biying, who's the administrator of the African Cancer Registry Network, and she's going to talk about the network itself. And then we have 4 speakers from Africa who are going to talk about some of the work that's being done by the teams in the network and some of the collaborating centers. So Biying, over to you.
Thank you, Max. There's still many people joining, so I will just give a couple of minutes. Yes, as Max said, that these talks were given in aortic last week. We had a fruitful meeting last week, and many of us were there.
Hi, Karen.
I will just mute the newly joined participants. And this meeting is recorded, and the recording will be shared later. Okay, all right, I think we can start. So just a quick introduction. My talk today would be cancer registration in Sub-Saharan Africa. So why do we care? Why should we care about that, since there are so many infectious diseases in Africa already? Because basically the population is large, 1.1 billion people live in Africa now. And also we are living longer, we're getting older. And also combined with infectious disease and other diseases, it makes the population more vulnerable to certain cancers. And also we are adopting the Western lifestyles, eating more meat, processed meat, eating fast food, sugar drinks, so all the unhealthy stuff, probably as well as healthy stuff, but we see the trends of going towards the West. And despite all that, we still have very poor health infrastructures on the ground. So it's a increasing threatening situation there. That's why we want to understand more. And that's why we are investing money and efforts into improving it. So we are quite familiar with this layout. This is a screenshot from Global Can from WHO IARC website. It gives you a lot of information. It shows an age standardized rate on the right-hand side, list of countries. But where did all these figures from? All these figures come from the population-based cancer registries on the ground. And you will see that there aren't many of them. And even they exist, they are very well underfunded and working in a rather challenging condition. So we are here to work with them and hopefully improve the work conditions for all this. So on the left-hand side is very familiar situation. That's how your medical record department looks like in your hospital. On the right-hand side is the beautiful, clean, neat, colorful pictures we often see on publications. How do we go from the left to the right? And just to explain, there are 3 types of registries: the hospital ones, pathologies, and population-based. Hospital registries gives you a lot more information on a personal level, the patient's individual levels, for administration purposes for the hospital. Pathologists for their own records have a lot more details on the results. This is newly joined. But none of this will give you the information on the population level. None of this will be suitable for use in cancer control planning for the population, either in a sub-region level or in national level. That's why we are focusing on population-based, which will give you the comprehensive picture of how the cancer profile looks like in the population, what are the stage, cancer types, and etc. So who are we? We are called the African Cancer Registry Network. As the name suggests, it's based in Saharan Africa. It works with cancer registries. We are a consortium of 35 members in 22 countries. As I mentioned before, there aren't many of us, only 35. And that's all the data is coming from at the moment. And here's the layout of our members. West, East, South. The central part is quite vacant at the moment. So if any of you are coming from the central part, your support, your input is needed. Now we have 3 centers because we think that, I forgot to mention that Max and myself are based in Oxford, UK. But thinking of that, the work for Africa should be done by people in Africa. So we decided to establish these 3 centers. Gonna chat. Oh, thank you, Max. Yeah, we decided to establish these 3 hubs in the continent. On the left-hand side, Côte d'Ivoire, they look after the registries in the Francophone countries. The right-hand side in Kenya, slightly shifted to Somali. No, not in Somali at the moment. It's supposed to be for Nairobi. It's the training center for the English part registries. And then the one down south is with the South African National Cancer Registries, and they look after research. At the moment, they are focusing on cervical linkage and childhood cancer registration. So our overall goal, of course, is to increase the number of registries, and if they do exist, we would like to enhance their quality and improve the data. And by doing so, we have 4 functions: training, consultancy, research, and advocacy. What's training imply? So courses in the past, before COVID, people travel, meet together, stay in the classrooms, listen to lectures, do exercise. When COVID came, we move on to online training. Together with IARC Learning and Vital Strategies, we developed this e-learning platforms, which covers all aspects of population cancer registration principles and use. And these materials are free. You need to register it, and then you can take all the courses. Each module you finish, you will get a sticker. And if you do finish all the modules within 12 months, you will get a certificate from IARC. So assessments, evaluations, regularly we send consultants to the site to look at how the work progress, what are the challenges. We have discussions, and we will bring in officials from WHO or IARC or governmental within in the nation to have discussion how to further support or improve the registries. And research, once a year, we do meet up together to discuss what has been done and what we will do in the near future. And then advocacy, we do what we can in newspapers, public domains, peer review articles, journals, posters at conference, talks. That's what we do. When we do have the data, we want to let people know that we have done a good job and what kind of impact we have. So we do our advocacies where possible. Of course, traveling to conferences is quite expensive, so that is limited. And what the data are for? The network collects our members submit their data annually to the network, and the data is stored in IARC database. What are they for? They are for they are used for prepare national estimates on incidence, mortality, and prevalence. And that's where you get your pictures and maps on the website. Our data from the ground to the database and then transfer into statistics where your government would sometimes go and pull them. So if your registry is included, you can proudly tell your government that our country's estimate is from us, not from the neighboring countries. So this is the highest level publication from population-based cancer registries. It's called the Cancer Incidence in 5 Continents. It has 12 volumes already. It started from, which year was it, Max?
1966.
1966. So the first volume, the tiny one on the left here, is started in 1966 all the way to volume 12, which came out this year. You can see the number of registries from Africa. It's never about 5 until very recently. That is because we had quite a lot of financial support from the Bloomberg Data for Health initiative, and they supported a lot of registry development and enhancements as well. So that is the high quality publication. There are registries who are new or work under suboptimal conditions, and where do the data go? We publish regularly publications on all member registry data. The top 2 ones are on adult cancers. The one below is on childhood cancers. So these 3 books cover all data from our 35 cancer registries. The good thing is these 3 books are free to download. If you go to the website, either UICC, IACR, or eCancer Journal, you will find them and they're free to download. So I will just briefly show you 2 major projects we have accomplished in the past 2 years. One is enhancing stage at diagnose. This was important because now we after 10 years of working on developing registries, we have quite a good quality of incident data, but a lot of information on stage is missing. And we do understand that information on stage is very important in terms of research, patients, treatment, planning, and prognosis. So we thought, why are they missing? Because doctor knew, but they didn't write it down. So we don't have the information. In that case, what do we do? Can our registrars do it themselves? So after a few pilot projects, we realized that if the registrars got sufficient training and if they have training materials in hand, it is possible that they can assign a stage. So we conducted this study. We collected a lot of clinical materials. We trained the registrars. We gave them the materials to stage, and then we compared to the golden stage, which was scored by doctors. And from the little chart on the right corner, you don't need to read the figures, but look at the yellow boxes. That is when they meet perfectly, when the scores were exactly the same as the golden standard. And it just shows you that our registrars can do it. There's a little poster that we presented in aortic. So based on that, we are now going to roll out another set of research projects. It's called the CIRCAN4 and the NORA treatment programs. And we will have our registrars to stage cancer cases in order to understand the current situation better. So the next project we complete, we spent 2 good years on this, is to establish this IAC GICR e-learning. That's what I mentioned earlier. So before COVID, everything was in classrooms, materials was developed for teaching, in-class teaching. So then we met with the expert, and the expert said, wait a minute, self-learning isn't quite the same as the materials isn't quite the same as in classroom teaching. So we work with them. the experts and Bloomberg and IT companies very hard and develop them into the lower part. You see the pictures. These materials are perfectly suited for self-learning. You can do it on your own pace. This whole set of e-learning covers 16 modules listed on the right-hand side, from preparation, what is cancer, all the way to how to use data, analyze them, and all the way to specific topics like pediatric cancer registration. So when this is officially launched, likely to be early 2024, then I will have a link on our website, then people can sign in and have a go yourself if you want to. Okay, a few more projects going to happen in next year. That is the CERFCAN-4 and the NORA treatment follow-up studies that I just mentioned. Our registrars will be calling patients to find out their vital status, staging the cases, and in a small subset, we will even interview patients to find out the treatment information. So all this information will be turned into very valuable publications. Second one is DHIS2 oncology module. It's a very heated topic at the moment. A lot of governments and hospitals turn into e-medical record, but whether this system, the information they collected, can be utilized by our registries, so our registrars don't have to do the manual labor work. But of course, it isn't so straightforward because cancer is a very complex disease, and we need to build in a lot of quality check to ensure that the information the hospitals collected is actually useful to us. So this is in a progress, and it's completed in Rwanda, and they are busy establishing training materials and guidelines which can help other countries to follow without going through the hurdles they had. Third one is costing too. So when you want to run your own registries and you go to your government or hospital and say, oh, I want a hospital, I want a registries, can you give me some money? And they will say, how much? And what can you tell them? Unless you know, you basically just a guess. So we do have a costing too. It has maybe 12 sessions, quite a lot of questions to answer. But if you do finish answering them, then you have a very precise figure for your application. The last one, but not least, is cervical screening linkage. So this talk will be covered by Dr. Siseka later. So thank you for listening, and I hope I make it in time. I will introduce our next speaker. You may have questions for me. You can put them in the chat, or if we have time towards the end, you may ask your questions as well. So we will have our next speaker, Siseka from South Africa, and he's heading this cervical linkage program, and he's from the GICR IAC research hub, a coordinating center. Yes, Siseka, over to you.
Good morning, good afternoon, colleagues, and thank you, Bing, for giving me this opportunity. May you kindly give me sharing rights, screen sharing rights?
Can you try? I don't have
Yes,
log.
okay, yes, I can share now.
Thank you. Right.
I'm able to share now, thank you. Thank you very much, colleagues. Let me try to put it on screen share. Okay, I hope you are seeing the correct screen, right? You're seeing the
It's good, yes.
Okay, thank you. So, as Bing has already introduced me, I'm Siseka Mashele. I'm the program coordinator for the IAC GICR Collaborating Center, which is the center in Johannesburg. So this afternoon or this morning, I will be presenting to you just the monitoring of cervical cancer screening and prevention in sub-Saharan Africa. So most of you may remember that in 2020 November, the WHO has put up a strategy to try to eliminate cervical cancer as a public health problem. And this strategy, it's here to say that if we can at least reach this 70-90 elimination target by 2030, we will be on the right path to eliminate cervical cancer in the next decade or in the next century. So the strategy just basically says that we need to at least vaccinate 90% of girls by the age of 15. So it means when a girl reach by the age of 15, they should at least be fully vaccinated. It's either with one, two or three doses, depending on the country. And the second pillar will say that at least if we can be able to screen 70% of women with high performance test at 35 as well as at age 45, we will be able to eliminate cervical cancer. And the last pillar it talks to pre-cancer treatment. So if we can be able to at least treat women with pre-cancer lesions, at least 90% of them by 2030, we will be able to eliminate cervical cancer. So they give us this target, and at the same time, they also give us the monitoring tool. How can we actually monitor this cervical cancer elimination? So they also tell us that within the newly diagnosed cancers, we can be able to do cervical cancer incidence by stage, age, and type. And we can also measure pre-cancer incidence by type and age. So among the people who are living with cancer, so these are the active cervical cancer cases that have already been diagnosed. So we can do cancer survival by type, by age, and by stage. So what is the problem that we have here in sub-Saharan Africa? So we know in most of the countries that our data systems are actually weak and fragmented. We have got data that are housed in silos, as you can see on my on the picture here, that within the cervical cancer care, we have the HPV vaccination, screening, treatment, population-based register, as well as the death registers. And in most of the countries in sub-Saharan Africa, these data are housed in silos. Whereas it's very important for us to be able to harmonize this population-based data so that we can be at least accurately measure the elimination progress. And the screening policies or screening modalities and frequency, they differ by countries and are often not driven by actually our local data because of these silos. So as the IAC Collaborating Center, what is the plan? What are we doing? So the plan for the Collaborating Center is to strengthen data-driven monitoring of cervical cancer screening. So this is through the training. So we're training African Cancer Registry Network member registries so that they are able to collate all relevant data sources. We train them on stakeholder engagement as well as probabilistic record linkage. And the plan is also to pilot the use of the record linkage of cancer registry data and cervical cancer screening registry in order to monitor the elimination progress. Okay. My screen is not moving. Okay, thank you. So what are the roles of the population-based cancer registry in evaluation of cervical cancer screening programs? So there are measurable outcomes in the cancer registry data. So this is the data that all the African Cancer Registry Network registries are collecting. So we can be able to measure the initial increase in cervical cancer incidence in the target population from screen detected cancers. And we can also be able to measure the long-term decrease in cancer incidence as a result of treatment of precancers. So when we treat the precancers, we will be able to see if there is a decrease in cancer incidence, as well as the long-term decrease in mortality due to early detection of precancers, because we know that once we start to detect cancers early, we will be able to, in the long-term run, we'll be able to see if we have a reduction in cervical cancer mortality. And lastly, we can also measure the decrease in tumor size, which is the stage 8 diagnosis, as cancers are identified earlier through the screening programs. So we are able to evaluate cervical cancer screening programs through the record linkage of screening registers as well as cancer registries, and we are able to do case control analysis. So the case control studies will help us to examine the risk of cervical cancer by screening status. And we can also measure the interval cancer. So the interval cancers, these are cancers that occur between screening tests after a previous negative screening test. So it's like if you have been screened negatively and later you develop cervical cancer. So with all these screening programs, you can be able to monitor all this. So what is the path to impact in this? So, creating evidence to inform harmonized screening policies in the region. So we will actually create this evidence of the harmonized screening policies in the region, because this training is for the entire region, and equipping countries with practical tools for data harmonization and skills for record linkage and facilitating stakeholder engagement. So because when we give this training, we not only train you on record linkage, we also do stakeholder engagement. So with the practical tools, you will be able to, all countries, different countries, will be able to facilitate the stakeholder engagement, because we know that since we spoke about the silos, obviously we need to have more of stakeholder engagement. And the data linkage training materials and tools for data harmonization, they will be made freely available on the African Cancer Registry Network website for all countries that need to use them. So meaning that after the training, we will put the training materials on the website so that whenever or whichever country that will need to use the training or to refer, they will be able to access them in the website. And the findings will be able will enable modeling estimations for the potential impact of scaling screening programs. So which means the extent, the coverage, and efficiency, we will be able to guide for the policy makers for cervical cancer elimination. So as the collaborating center, we had our first cohort of training that was 5 weeks, happened between February and March early this year. So this was only the online record linkage training, where participants were given all the resources that they needed for them to be able to do this training. These are some of from the pictorials that you see here, these are some of the people who have participated on the online training. But from the online training, we have selected the participants depending on the need and the requirements of the country, participants to come to South Africa to do the in-person training. So in this training, all participants came to South Africa with their own different database or data sets that we assisted them to at least link them so that they have all these records in one database. So this training was in person. It was here in South Africa in June this year. So I would like to acknowledge all the people here, most importantly, Vital Strategies, for continuously supporting the work of the collaborating center. And thank you very much.
Thank you so much, Siseka. Yes. So now you hear a bit more details about this cervical screening linkage. They do provide training. E-training is very easy to join, and we will advertise that when the next one comes. In-personal training, of course, is depending on money a lot, and it would be quite selective depending on the candidate's conditions as well as the countries. If the country has nothing on the ground, then the training isn't so fruitful. But do keep in touch, and when the materials are available on the website, then you can have a look and download them and study them on your own pace. Now we will have our next speakers. The topic would be breast cancer in Africa, time trends, stage, and survival, and it will be presented by Dr. Yvonne Joko. She's based in University of Cambridge at the moment. She's originally from Cameroon. She did a PhD with Dr. Parkin here in Oxford some years back. She has a lot of experience in terms of analyzing survival data. So Yvonne, hang over to you.
Debbie, thanks very much for the introduction. So today I'm going to be talking about breast cancer in sub-Saharan Africa, and I'll be talking about time trends, stage, and survival. This work I'm presenting is on behalf of all the registries and member registries of the African Cancer Registry Network, without whom this work would not be possible. So why breast cancer? Breast cancer is the most common cause of cancer in sub-Saharan Africa, and it's the second highest cause of cancer mortality after cervical cancer. In 2020, there were close to 67,000 deaths from breast cancer in Africa, which is a huge loss of lives and with huge effects on families and the economies of these countries. So when we started our PhD and our studies with Dr. Max Parkin, what questions were we trying to answer? So the first question was, does breast cancer occur more frequently in younger women compared to older women in sub-Saharan Africa? And why were we asking this question? Because a lot of the hospital reports showed a relatively high proportion of younger women from the hospital-based registries. We wanted to find out if this was true when we looked at population level data. The second question we tried to find out was what population level risk factors could be driving changes in breast cancer incidence across sub-Saharan Africa. And the last, once they do develop breast cancer, what were the survival outcomes and what were the determinants of these survival outcomes? In order to study breast cancer trends in sub-Saharan Africa, we need quality data over several years. But however, when we look at cancer incidence in 5 continents, some of this was presented by Bing earlier, we have data from Uganda and Zimbabwe only, which show up in more than 4 editions. So in order to study trends, this was very challenging before all the work which is being carried out by the African Cancer Registry Network. So in order to study the trends, most often people will go to the IARC website. So this is an image from the Global Can website. And here, what we're seeing is comparing the breast cancer incidence rates among US Black women and among women from Uganda. The first thing we see is this huge difference in incidence rates, but we also observe this rapid increase in incidence rates in Uganda over time. So we wanted to see if we have this similarly rapid rates of increase across different African registries. So how do we go about it? This was all thanks to the work of the African Cancer Registry Network. And the African Registry Network provides a unified framework for data collection, collaboration, and research between different population-based registries. So all the registrars and all the registries use the CanReg 5 software developed by IARC for data entry and internal quality checks, which made it easier for us to use the data to study trends in a harmonized way. So what did we find out? So we found out first that there were differences in the magnitude or the incidence rates between different countries in sub-Saharan Africa. So the rate of increase was not homogeneous across sub-Saharan Africa. So some countries with higher HDI, such as Mauritius and Seychelles, we had relatively higher incidence rates, as well as in urban capitals like here, Harare. But when we looked at more rural areas, this in black is the Eastern Cape Registry of South Africa. We see that the incidence rates were much lower in this rural registry, and also in the Gambia, which had one of the lowest incidence rates in our registries. Now, comparing the incidence trends between women 50 plus and women under the age of 50, we compared these incidence rates in 14 different registries. So what we have in pink are women age 50 and above, and what we have in blue are women under age 50. So we see that for all our registries, we have a higher breast cancer burden among postmenopausal women compared with younger women. Now, looking at these changes over time, we studied successive generations of women. So if I take this blue line as an example, this represents women diagnosed with breast cancer aged between 40 and 45. So what we have here is a woman who was born in women born in 1950 with breast cancer in this age group. And what we have here are women born in 1970 with breast cancer in this age group. So what we're saying is that for women at the same age with successive generations, we are having an increase in the burden of breast cancer over time. So what may be driving these increases or changes in the burden of breast cancer over time? We try to look at population level ecologic risk factors. So this data is not from our cancer patients, but this is data at population level on different risk factors for breast cancer. So this graphic shows the mean BMI over time for the different countries, which we included in our analysis of time trends. So what we observe is an increase in the mean BMI over time for all these countries at country level. And when we look at another known risk factor, the use of contraceptive, we see that there is a differential uptake of contraceptive use across the continent, and there is an increase in the later years in some countries. So some of this may be driving some of the changes in the breast cancer incidence we see. Another important factor which has changed over time are the fertility rates. So this graphic on the right shows the change in the total fertility rates over time from the 1950s to 2020, with the total number of children a woman has going from about 7 on average in the 1950s, and it's approximately 2.5 for many of these countries in present years. So what are we seeing from all this? That there's a heterogeneous risk factor distribution across sub-Saharan Africa, and this may be responsible for some of the changes in the breast cancer incidence rates we observe across the continent. So these changes in reproductive patterns like decreasing age at menarche, fewer children, increased uptake of contraceptives, and the fact that this is not homogeneous across the continent may explain the homogeneity in our changes in incidence rates. So once a woman has breast cancer, what are the survival outcomes of our patients? So first, I want to highlight this data has been published before from the registries, and it shows the disparity in breast cancer survival across sub-Saharan Africa. So at 5 years, in some parts of sub-Saharan Africa, a woman's chances of survival will be close to 80%. Meanwhile, in other countries, it will be less than 40%. So we see this huge disparity in cancer survival across the continent. So we try to understand what could be driving these disparities across the continent. So we did a smaller study in collaboration with the University of Halle, and we selected about 800 women for whom we had a more detailed look into the medical records on factors such as the treatment they actually received, their stage, and how this affected their survival outcomes. So these were some of their patient characteristics. The first thing was that patients, more than about 66% of patients were diagnosed at stage 3 and 4. So this is a relatively very high proportion. So two in 3 women will be seen at advanced stage at diagnosis. When it came to other important characteristics for treatment, 1 in 5 women met the minimum diagnostic criteria. That's for women for whom we had their stage and their hormone receptor status known. And the hormone receptor status was not known for close to 70% of our patients. And for all the patients, 55% of patients with curable breast cancer, so breast cancer diagnosis at stage 1 to 3, had inadequate treatment or did not have any cancer-directed therapy. So how did this influence survival? So we see that for the women who did not receive adequate therapy, their survival chances were 4 times worse than women who received adequate therapy. And for patients diagnosed at advanced stages, this is like stage 3, they had 3 times increased hazards of death compared to somebody seen at stages 1 and 2. Hence the importance of downstaging breast cancer and improving access to care. But once we are adjusted for the treatment received and the stage of diagnosis, the country level HDI, so whether or not the country was reached, this effect was no longer observed. So what do we conclude from our work? So the first was that the incidence of breast cancer is rising among women of all ages in sub-Saharan Africa, but the fastest changes in incidence is observed among women over age 50. The changes in demographics and lifestyles in successive generations could possibly be responsible for some of these increases, but we need more detailed risk factor studies at population level in sub-Saharan Africa. And for the women who have already been diagnosed with breast cancer, we need to improve access to earlier diagnostics and treatment for breast cancer in sub-Saharan Africa. So thank you very much for listening.
Thank you so much, Yvonne. Over time, Yvonne has become an expert on breast cancer in Africa. So just to remind the new joiners, today we have this African Cancer Registry Network session. It covers 5 talks. The first one was given by myself on the cancer registration in Africa. Dr. Siseka already gave his presentations on the cervical cancer screening linkage. And then we just heard what Dr. Yvonne gave the presentation, breast cancer in Africa. So now our next speaker will be Professor Mulukan, professor from Addis Ababa University, Ethiopia. Over to you.
Thank you very much, Big, for the kind introduction. Can you allow me to share the screen? Yeah, now let's go. You can see my screen.
Yes, it's good.
Yeah, thank you. Hi everyone. This is Mulukan from School of Public Health at Addis Ababa University. So today I'll be quickly present on the trends in the incidence of the major cancers in sub-Saharan Africa. So I would like to thank all of you, for generating this wonderful data, for us to analyze and also provide some important evidences to contribute globally, and of course also to guide our policy at the regional level. So for that, I'm very much happy to present some of the results to you directly. As you know, what's really the rationale to analyze data or to see time trends analysis? So as Yvonne and the previous speaker said, the cancer is rising. So when we see the increasing trend, it's important also to see back if we have special exposure or environmental or what different kind of exposure playing a role in our region. Also, it would also help to generate ecological hypothesis, what's really going on or what changes really happening in our region in sub-Saharan Africa. So when we see the trends, it gives us a chance to see important ecological factors really contributing for the changes happening in our region. And also it would also help us for providing evidences in cancer control programs, be it to see the effect of intervention, effect of prevention intervention, which are planned or unplanned, and so to see the program of early detection, as Isaac presented, for the integration of screening and cancer screening and cancer for cervical cancer. So that's also helps to evaluate the program of early detection and the screening program, and also to see the efficacy of treatment region. So these are some of the importance of looking the cancer trends over time. I mean, after we get the data from the cancer registry, we analyze the data. We analyze the data by using different statistical approach. First, after the abstracting the data from the AFCRN, we first evaluate for the quality of the registration process, especially for the trend analysis. At least we need the data for 10 years and above. So one of the quality parameter would be, the years or the number of years the registry could provide or could contribute from specific cancer. And also we use the population data also derived from the census estimate, or intercensal estimate also could be generated by having an assumption of exponential growth of the population in a given society or in a given country. We calculate annual age-specific, crude, and age-adjusted rate will be calculated. So standardization also carried out by using a direct method. As you know, there are direct and indirect method, but mostly we use indirect method by using the world standard population from the WHO world population. And to see whether the trends will have a statistical significance over time, we use a joint point regression. So that means we see the different time pointers in which the time trends would show the significant changes over time or not. And we calculate also the average annual % change in each trend segment to see whether the changes is positive or negative or declining or increasing over time. So for this presentation, we have collected data from on different cancer types, mainly breast cancer, cervical, ovarian cancer, prostate cancer, and colorectal cancer. You know, these are the major cancers. Major cancers happening or we are seeing in our region. So for breast cancer, about 11 registries were contributed from 10 countries, and 18,000 of the new cases or incident cases were included. So for cervical, ovarian, prostate, and the colorectal cancer, if you see the percentage of morphologically verified cases, you see the discrepancy, or you can see the which is, for instance, for breast cancer, it ranges from 58% in Kampala to 98% in Mauritius, and maybe for colorectal cancer, only 2% in the Gambia and 94% in Mauritius. So there is a huge discrepancy on a percentage of morphologically verified cases across the cancer registry, countries contributing for cancer registry for the AFCRN. I will not go in detail on the breast cancer because you want us presented very well. So you can see this is the same data. You can see the increasing trends over time in most of the countries. Maybe perhaps if you see here, I mean, you can see by dissecting the data in different period of diagnosis, so which shows the highest changes we're seeing in recent years. In most of the countries, you can see the highest changes has been occurred in the recent years. That is that shows clear indication for increasing trends over time on breast cancer in Sub-Saharan Africa. Hello?
Yeah, you do.
So this is for cervical cancer. So in general, you can see increasing trends over time for cervical cancer. So in most countries, there is increasing trends, and even in most countries, the increasing trend is statistically also significant. So unlike two countries in Sub-Saharan Africa, if you can see the developing countries, cervical cancer is decreasing over time, but in Sub-Saharan Africa, still the cervical cancer is increasing. So, I mean, this is just for comparison for us to exert a huge effort in controlling and preventing cervical cancer. As you know, cervical cancer is it can be prevented by instituting appropriate prevention actions. So it's I would like to call for for joint effort in exerting efforts to decrease the trends of cervical cancer in our region, because we are having a lot of burden due to the cervical cancer. So this is for ovarian cancer. For ovarian cancer, as you can see, with the average annual percentage change, you can see there is a positive changes over time in most of the countries except Congo and the Gambia. But if you see the Mali, Nigeria, and Eastern Cape, you can see statistical significant changes over time with the highest average annual percentage changes. So we have seen also for ovarian cancer, we have seen the trends by different histological types. So as you can see here, as a driving force for a high increase of trends in ovarian cancer is due to epithelial cancer. So epithelial cancer is the reason for, for increasing trends of ovarian cancer in sub-Saharan Africa. So this is true, or was true in Mali, Ibadan, Eastern Cape, and Mauritius, but it's the same in other countries, but we're not statistically significant. So we see the same trend or increasing trend for prostate cancer. So from data from at least from 12 countries. So you can see which is the 3 years moving average, with the dot represented the observed values. So after adjusting, for when we see the 3 years moving average, it seems there is a clear indication for increasing trends of ovarian prostate cancer over time in sub-Saharan Africa. So like that of breast cancer, the highest increase of trends of prostate cancer was seen in recent years. So for comparison, this is over prostate cancer from other developed countries. So still the same trends in other part of the world too. So which is consistent with the data from elsewhere, from other regions. The last one is colorectal cancer. In the colorectal cancer, you can see there is increasing trend of colorectal cancer from sub-Saharan Africa. So still, it seems it's a very jaggy, but you can see the trends is also increasing, especially in Eastern Cape and from Mauritius data. There is a clear indication for increasing trend. It's also the same in other countries in sub-Saharan Africa. So just to conclude, there is increasing trends have been seen for all major cancers in sub-Saharan Africa. Of course, there were differences with the region. So we have seen differences within the region. So all countries are not showing the same increase or the same characteristics of with the cancer incidence or trends in cancer incidence, but there is a difference. Especially the increasing trend may have an implication with a global initiative like cervical cancer elimination plan, which is the threshold is 4 out of 100,000, but we are having a huge burden in sub-Saharan Africa. So that could be one of the implications. I mean, yeah, as I've said, we should exert a lot of effort to attain this threshold or this goal. And the increasing cancer incidence in sub-Saharan Africa suggests also the need to strengthen the prevention and treatment services. And the variation of the morphological verified cases suggests the strengthening of pathology surface in the region. And we should also improve the data capturing further by improving the quality of the data. And we have called, and also I would like to reiterate also the support. We should provide the support for the population-based cancer registries to get quality and appropriate data. Thank you.
Thank you so much for packing so much information into such a short time, such a small space. So we all assume that, well, we don't assume, we always say that there are more and more cancers in Africa. Is it really true? When we look at the data, it is true in many countries, that there isn't in some of the cancer sites in some countries. So we shouldn't just claim, we should look at the evidence before we make a statement. So thank you to all the registries. We were able to do such a conclusion on these important cancer types. So we have our last but not least speaker. I will just quickly.
Hello.
It would be Dr. Lydia from the Rwanda National Cancer Registries, Rwanda Biomedical Center. And she will be giving the last presentation on cancer, childhood cancer in Africa. She's also an expert on DHIS2, but today we will just pick her brain on the pediatric cancer registries. So over to you, Lydia.
Thank you so much. Hi, everyone. Let me share with. Okay. Okay. Hi, everyone. Thank you so much for this time being. I think can you see my screen? Hello?
Yes, we can see it.
Yes, Lydia, we can.
Okay.
Yes,
I have the internet issue here, but I'm going to try. So let's go ahead and look at how childhood cancers are different to adult cancers. Childhood cancers are very rare and only make up to 0.5% of all cancers in high-income countries, and only 4% of all cancers in the African continent. They have different biology. That is, they are embryonal tumors, which means these cancers are of development gone wrong. Childhood cancers have different etiological. So the factors, the etiological or causation factors of childhood cancers are essentially unknown and not preventable with current knowledge. They have specific histological classification system, that is ICC3. It is International Classification of Childhood Cancers, 3rd edition. And also, these cancers have different staging, and the staging of childhood cancer is big. They have different staging system to adult cancers. The TNM system is a standard staging system for most adult cancers. However, it is not inadequate for documenting extent of disease in children, and it is not appropriate. Disease-specific staging systems have been developed for childhood cancers, but for many diagnostic groups, 2 or more systems are in clinical use, and there is no international uniform standard suitable for childhood cancer for the population-based cancer registries. Childhood registries often do not record stage for the main reason that it is usually not documented in the medical records, and staging of childhood cancers remains a problem. Studies of cancers in children in sub-Saharan Africa are even more difficult than those of adults. Information on occurrence and survival of cancer at population level can only be obtained through population-based cancer registries. Most African population-based cancer registries cover limited subnational populations, so that the number of pediatric cases recorded each year is relatively small. You might be asking that why attention on childhood cancers? The answer is WHO has launched the Global Initiative on Childhood Cancers in 2018. They have highlighted the inequity in survival rates of children with cancer in developed countries versus low and middle income countries. The global initiative aims to improve outcomes for children to achieve survival rate of at least 60% in children with cancer. Currently, there is no special registries for childhood cancers that cover all cases in particular population. There have been 2 efforts made to address this issue. In 2017 to 2019, the My Child Matters program of the Sinof Espoir Foundation supported national cancer registries in Burkina Faso, Cote d'Ivoire, and the Republic of Congo. Despite of encouraging results, the chairman of the expert committee from USA denied the further support for that program. Then in 2020 to 2021, a 1-year project in Southern Africa funded by African Oxford Research Development Award Program supported pilot projects in 5 countries of Southern Africa. However, despite the rollout of WHO's global initiative on childhood cancer, it has been very difficult to find funding to review such an effort. So all the information you have here on childhood cancer, rates in Sub-Saharan Africa are from general population-based cancer registries, recording cancers occurring at all ages in the population. All of the quality assured population-based cancer registries in Sub-Saharan Africa are members of the African Cancer Registry Network. At present, it consists of 33 population-based cancer registries from 22 countries. Because of lack of recent data, because of the lack of recent data on childhood cancers in Africa, in 2014 here, the African Cancer Registry Network put together the data on childhood cancer from 16 members of African Cancer Registry Network. The results were published by eCancer, both as monograph shown here and by a summary paper. The monograph shows some summary comparative incidence rates and also some charts showing incidence in different age groups. Here you can see that
Lydia, we cannot hear you. So I guess Lydia is experiencing some technical issues. We just give her a minute to see whether she comes back. Lydia, we cannot hear you.
do you hear me?
Yeah, now it's good. Thank you.
Oh. Sorry. Do you get me?
It's good.
So here you can see some results. One, you can see that lymphoma or leukemia appear to be rare in African children than in USA or Europe. And the same applies to children of African descent living in the USA. On the other hand, you can see that Williams tumor is also appear to have rather high incidence rates in most African countries than other countries. So when you see at stage at diagnosis is a very important prognostic factor for childhood registries. It is the most determinant of survival and also objective indicator of lateness of disease. So the ATM system is inadequate for documenting extent of disease in children. Until recently, there was no international uniform standard suitable for population-based cancer registration. To address this issue, to address the lack of uniform system, the Toronto guidelines were introduced by a consensus group of experts in 2017. These Toronto guidelines allow a two-tiered approach depending on diagnostic capacity for Africa. The African Cancer Registry Network has been encouraging the use of staging of the tier 1 level. This separates cancer into 2 or 3 levels of spread that have prognostic significance impact. Here you can see the two manuals that have been developed for staging of childhood cancers. So the African Cancer Registry Network has developed training progress. They have developed training progress programs for cancer registries, teaching them how to abstract stage from clinical records using these guidelines. Their success in staging of childhood cancers was recently validated in a study comparing the results of cancer registries with those of experienced pediatric oncologists. We have described this project in the posters that were presented in the in the aortic conference last 2 weeks back. So these are the some results from a recent project in which staff of the Rwanda Cancer Registry were trained to record stage at diagnosis for childhood cancers using tier 1 classification of Toronto consensus principles. Most cancers were, as you can see here, were successfully staged by registry staff using the Toronto guidelines. As we see here, for the most 4 cancers staged, 97% of Williams tumor were successfully staged. So by improving survival from cancer in children is a prime aim of the global initiative of World Health Organization that was launched in 2018. Unfortunately, however, little attention has been given to documenting the current situation with respect to survival rate, with respect to the first survival, let alone how to see if any improvement are occurring. Because of this, African Cancer Registry Network has been working with members of registries to equip them to collect follow-up information and to calculate population level survival. The first project took place in 3 registries in 2014. Then in 2021, the new study was done in Rwanda Cancer Registry, this time with stage at diagnosis. The study looked at 8 types of cancers of children, from children aged 0 to 14, and also we followed up to, from Rwanda Cancer Registry from 2013 to 2017, and followed up until the end of 2021. As you see here, the study, you can see that 4 cancers shows that the survival at 3 years were strongly influenced by the stage of the disease. The overall lower of survival was primarily due to a high increase of number of cases being detected at late stages. You can see here the survival of localized disease is quite good, especially for retinoblastoma. So in conclusion, cancer registration and cancer surveillance in general are underdeveloped in Africa. Many countries do not even have a single population-based cancer registry. The situation for childhood cancer is even worse. Despite of these efforts of African Cancer Registry Network, there are still no dedicated population-based cancer registries for childhood cancer. Thank you so much for your kind attention.
Thank you so much, Lydia.
Hello.
And thank you to all for staying to the end. Childhood cancer is not preventable to our current knowledge. That's why we want to look after the children if they do get it, unfortunately. So this is the end of our session. We have given 5 talks. The presentations will be made available in PDF forms, and here's the website, our website, and I will put the link for downloading the videos as well on the website. So give me a couple of days, maybe next week, if you check our website, the materials will be there. So thank you all, and I wish you all have a lovely, lovely day, and thank you for joining us today. Thank you for all your time.
Thank you. Bye.
Thank you. Bye.
Thanks, Max.
Great
Can we have
session.
a photograph taken, please, before we all disperse?
All right, for those who wish to take a
See you
picture,
at the end.
switch on your camera and I will do it.
I think it would be nice
Yeah.
to take a picture.
All right. Yes, of course. Professor Emma, you are right.
And especially because today is my birthday.
Oh,
Oh, yes, your birthday. Happy birthday, Professor Emma. So Professor Emma is from Calabar, Nigeria. She has the cancer registry there for many years. So for those who are willing to have their face taken, then
Hello, everybody.
so I will
Hi,
keep
Thomas.
on looking at your camera and I will take multiple shots. Thank you for joining. Okay, 1.
Thank
and
you,
then I
Lydia, for that beautiful presentation.
will 2.
Nice to see you, Lydia.
Yeah, so all our speakers can be reached through me, I guess, for now. So if you do have questions for the speakers, please just message me. I will take another one. Then, oh, I need to find the Zoom. What happened to my Zoom? Hey, do I still have the Zoom? Oh, yes, I do. Okay, one last try. Smile at the camera. All right, thank you so much, everyone. Bye for now. And speak soon.
Bye, Max.
Bye.
Bye, Vin.
wow.
Thank you very much, Yvonne. And thank you, Seka. Hello, Teresa.
Happy birthday, Ima.
Thank you very much.
Many happy returns.
Bye.
Thank you. Hello, Tokwe. Hello, Max.
Hello, Prof. Happy birthday.
Oh, thank you very much.
That's a boogie.
Happy birthday, Ma.
Thank you, Lydia.
So I shall end
Thank you,
now. Happy
everyone.
birthday, Professor. Goodbye and
Thank you
good day.
very much.
Bye.
Goodbye. Bye-bye.